So, HIV is the human immunodeficiency virus. It's a viral infection that reduces the efficiency of the human immune system. And eventually, the immunocompromise will reach such a degree that the patient starts to suffer from AIDS, acquired immunodeficiency syndrome. This is a syndrome because it has many possible clinical features. So, like a sign is something that you see, a symptom is something the patient reports, but a syndrome is many possible signs and symptoms. Because what particular clinical features you present with HIV depends on the type of infection you get, and you can get many different types of infection because of the immunocompromise. And also AIDS is acquired immune deficiency syndrome. This means you catch it. At one time you were not immunodeficient, and then you become immune deficient as a result of infection with the HIV virus. Now, epidemiology describes the pattern of disease distribution. And HIV started in Africa, but then spread to other Western countries, and it's now all around the world. HIV infection is pretty well everywhere now. Most cases still occur in sub-Saharan Africa, but it's also increasing in quite a few countries of the world, like India, for example. But you get it everywhere now. You get it in South America, you get it in Russia, you get it in China. It's a pandemic. It's all over the world now. In some countries it's increasing, but other countries, they've got good health education programs going now, and people are starting to realise that this is a transmissible, life-threatening disease. And in quite a few countries now, the amount of new cases is declining. Now, there's still plenty of cases around. We're not short of HIV infection, but it's reassuring that in quite a few countries now, the incidence of new cases is declining. Now, it's interesting that HIV is a new disease. The virus was first identified in 1981. And what happened was the virus probably jumped from monkeys to humans in sub-Saharan Africa, perhaps in something like the 1920s. And probably it jumped from monkeys to humans as a result of humans hunting and eating monkeys, or a human being bitten by a monkey. But that actually means it's an example of a zoonosis. It's a disease which has been transmitted from animals. Now, the HIV virus itself is described as a retrovirus. This means its genetic material is RNA as opposed to DNA. And what these viruses do is they come along beside a cell that they want to infect. And the HIV virus particularly affects lymphocytes, T helper lymphocytes in humans. So the virus comes along beside the cell it wants to infect, and it injects its genetic material into the cell. It injects its RNA into the cell. And it also injects another substance called reverse transcriptase. And what this reverse transcriptase does is it converts the viral RNA into DNA in the nucleus of the host cell. And then this DNA in the nucleus of the host cell gives orders to the protein-producing apparatus in the host cell, that is to the ribosomes, to produce new viral particles. So basically it's a bit of a hijack, it's a bit of a takeover. The virus has got into the very genetic material of the host cell, taken that over, hijacked the whole thing, and it makes the cell produce new viral particles. And this is the way viruses work. They get into cells and they take over and damage cells. Retroviruses particularly take over cells to make new viral particles. And once these new viral particles are produced, they bud out of the cell, and then they're free to go and infect other cells, and they will go and infect other cells. And the original infected cell dies probably within a few days. This, of course, has two bad consequences. One is it kills the infected T lymphocyte, and the other is that many more viruses have been produced that can go on and infect other cells, or indeed be passed on to other people via cross-infection. So that brings us on to disease transmission. How is this disease transmitted? How is it spread? Well, I think everyone knows it's spread sexually. So it can be spread by heterosexual vaginal sex or oral sex. And it's particularly easy to spread HIV with anal sex, regardless of whether that anal sex is homosexual or heterosexual. And this is because the lining of the rectum is very thin, it's only a simple epithelium, and any trauma is likely to lead to bleeding, meaning seminal fluid comes into direct contact with the blood, making transmission really quite likely. So there's the sexual route of spread. And this is actually explained by the fact that you get viruses in the blood, but the virus is also secreted in some body fluids. Now you get a little bit of the virus, low viral numbers in saliva, low viral numbers in urine, low viral numbers in feces. So you can't say these things aren't infected, but the risk of infection is very small because the number of viruses shed is very small. But in seminal fluid, very large numbers of the virus are shed into the seminal fluid. And in cervical secretions, very large numbers of the virus are shed in cervical secretions. And the higher someone's viral load, the more viruses someone has in their blood, the more viruses they will shed in their seminal fluid, the more viruses they will shed in their cervical secretions, and therefore the more infectious they will be. And because the virus is in blood, it can also be transmitted by blood. Any blood-to-blood contact gives something like a 90% probability that the virus will be transmitted. So that is blood transfusions and blood products. But there's also a risk that if someone at work stabs themselves with a dirty needle or cuts themselves with a dirty scalpel blade that's been used on a patient with HIV infection, then that can be passed on via this nosocomial healthcare acquired infection route. This is also why we should wear gloves if we're dealing with body fluids, because even if HIV infected blood gets onto the skin, it probably won't cause infection, but if it gets through little cuts in the skin or nicks in the skin, then it certainly can. And another risk is splashing yourself with blood in your eyes. That can transmit the virus. That's why in theatre, if there was blood being splashed around the place, you would wear goggles and face protection. So it's sexual spread, blood-borne spread, and the other one is mother-to-child vertical transmission. So mothers can give the virus to their children. Now, in the process of birth, there can be mixing of maternal and fetal blood, which obviously carries a risk, and the virus is also shed in breast milk, so breastfeeding can be another possible form of transmission of the virus. It's reassuring to note that HIV is not spread by insects and it is not spread by social contact. So holding hands with someone, hugging someone who's got HIV would all be perfectly safe. Now, kissing is a slightly more questionable one. Very low amounts of the virus are shed in saliva, but with enthusiastic kissing there is going to be some mixing of saliva, and some viral particles could get from one person's mouth into another. Now, if both people have an intact mucous membrane in the mouth, transmission is very unlikely. So, can you say kissing is completely safe? No, you can't. Is transmission with kissing likely? No, it's not likely. There's also a slightly increased risk of a woman catching HIV from a man as opposed to a man catching it from a woman as a result of normal heterosexual activity. And this is because the seminal fluid from the man can remain in the woman for several days after the sexual encounter. So there's plenty of time for the virus to get into the woman's body. Now let's think now about the evolution of the infection. What happens? Well, first of all, there's infection when the virus gets into the body and the virus gets into the host's T helper cells. That's the first thing, that's infection. Then there's going to be a short incubation period. And this short incubation period will typically be 4 to 8 weeks. And then the person normally becomes sick. They feel unwell with a flu-like illness for a few days. And this is associated with seroconversion. This is the point at which the virus has stimulated the immune system to make HIV antibodies, and the person becomes HIV antibody positive. The serum changes from being HIV antibody negative to being HIV antibody positive. And this is the way we normally diagnose the condition. Now, you can look for viral RNA in the blood of an infected person, but that's quite hard to do, and it's quite a sophisticated test. But it's easier to look for the antibodies that the immune system has made in response to exposure to the virus. So the virus will stimulate the immune system to make antibodies, and these antibodies can be detected in the blood. So we talk about someone being antibody negative or antibody positive. Antibody positive means that they do have the antigen, that is, they do have the virus, and it has stimulated an immune response. Then following this, there's quite a long period of time, maybe 7 to 10 years, where there's no symptoms or only minor symptoms. This goes on for quite a long time, the asymptomatic phase. And then, as the CD4 count goes down, that is, as the number of T helper cells goes down, the immune system can drop to such a point that the person starts getting infections, and we call this ARC, AIDS-related complex. They start to get some infections. But then as the infections get worse, we call that AIDS, full-blown acquired immune deficiency syndrome. And typically 2 to 3 years after the onset of the AIDS-related complex, without treatment, the patient will die. Different people actually classify the evolution of the disease differently. Some medical textbooks will say Group 1 is the seroconversion illness, they're Group 1 symptoms. Group 2 symptoms are the asymptomatic phase. In Group 3 symptoms, you can get persistent generalized lymphadenopathy. Lymphadenopathy describes swelling of the lymph glands, for example in the groin or in the axilla, and this is a persistent problem in Group 3 symptoms. And in Group 4 symptoms, they describe this as AIDS-related complex and full-blown AIDS, where the patient gets symptomatic infections. The Centre for Disease Control, Atlanta, in the United States, they say phase A of the infection is asymptomatic infection, phase B is mildly symptomatic disease, and phase C is full-blown AIDS. So plenty of different ways you can describe it. But basically there's a short incubation, a seroconversion, an asymptomatic phase with or without persistent generalized lymphadenopathy, followed by frank immunosuppression and opportunistic infectious diseases. That's the way it goes. Now, I mentioned CD4 counts there, so what does this CD4 mean? Well, CD4 is the name of a receptor protein on the surface of the T helper lymphocytes, and it is the way that the HI virus gets into the T helper cell. What happens is that part of the outer coating of the HI virus sticks onto this CD4 receptor, and that's the only thing it can stick onto. It has to have a CD4 receptor to stick onto. So CD4 receptors are found on the surface of T helper cells. And what the people in laboratories like to do is they can measure the amount of CD4 receptors in the blood. They seem to find this easier than measuring the amount of T helper cells directly. So, if the CD4 count is high, that is a proxy, meaning that there's plenty of T helper lymphocytes in the blood, so immunity is likely to be good. If the CD4 count goes down, that's a proxy for low levels of T lymphocytes in the blood, and the immunity is likely to be compromised. And as the CD4 count goes down, viral load goes up. Or to put it another way, the more viruses there are around, the higher the viral load, the more CD4 T helper lymphocytes will be killed. So as the disease progresses, CD4 count will gradually go down and viral load will gradually go up. And then patients will start getting conditions which are typical in HIV infection. So Candida is one, which is a fungal infection that can affect the mouth and vagina. Another classic infection they get is PCP. This stands for Pneumocystis carnii pneumonia. And this Pneumocystis carnii is a bit of a strange organism. We used to say it was a protozoa, but it's also got biological characteristics which make it a bit like a fungus. So I kind of think of it as being halfway between a protozoa and a fungus. But whatever, it causes pneumonia, and in pneumonia you get consolidation of the lungs, the alveoli fill up with fluid, and of course that's a life-threatening condition. Another classic feature is cryptococcal meningitis. This is caused by a fungal infection, and it causes meningitis. It only occurs, as far as I know, in people with HIV. Meningitis is normally bacterial or viral. So you might have come across meningococcal meningitis or Haemophilus meningitis or viral meningitis, but the only time you're going to come across the cryptococcal fungal form of meningitis is in patients who have HIV infection. But both life-threatening conditions, the PCP, the pneumonia and the cryptococcal meningitis, without treatment, both of these can result in death. And there's many other so-called opportunistic infections. The idea here is that the infections seize the opportunity afforded by the immunocompromised body and infect it. And one of the classic ones that people with HIV get is tuberculosis. This is especially true in a lot of areas of the world like Africa and Asia, where there's already a lot of tuberculosis around, and the combination of the immunosuppression caused by the HIV and the ready availability of the tuberculosis bacteria make infection really quite likely. So very often the two diseases do go together in the same person. Right, let's think about management. Well, these patients need highly active antiretroviral therapy. And these drugs are very effective. They won't cure the condition, but they'll keep the viral load very low. The patient will immediately feel massively better, go back to work, and probably live for another 20 or so years. It is a massive improvement in lifestyle and life expectancy if someone is given normally 3 antiretroviral drugs at the same time. And it's particularly important in pregnancy. If the viral load is low in pregnancy, especially the later stages of pregnancy, then that means that the baby is less likely to get HIV from the mother as a result of vertical transmission. So we can't cure HIV, that means we need to prevent it. So we need to tell people how HIV is transmitted and try and avoid transmission of the virus. That would mean avoiding unprotected sex unless it is known that the patient or the potential partner is HIV negative. It would mean never sharing needles. It would certainly mean avoiding homosexual or heterosexual anal sex. It means us taking care at work not to stab ourselves with dirty needles or other contaminated equipment. We need to prevent the spread of this virus. If we do that, theoretically the virus will die out, which would be very good. Which would be very good. Which would be very good.